Welcome, everyone. I'm Alan Greiner. I apologize for not being there physically as I had originally intended. I double booked myself, as I sometimes do. I'm at a rural health equity conference over here in Colorado Springs with some Colorado and Kansas rural physicians. But we have a great session planned today, and I think with our technological helpers on that end, I think this should all go great. And we've got two fantastic speakers that are doing and have done amazing work, and I think we'll be able to really enlighten us about some of the really cool outreach and community engagement activities that emanate out from both KU Medical Center and KU Lawrence and kind of all of our campuses. So I'll just give a brief introduction of who I am. So Alan Greiner, family physician. I've been in the Department of Family Medicine at KU Med Center for 23 years now. I'm the vice chair of the department now, and also do a fair amount of community engagement work. I'm the health officer in Wyandotte County, and I run the community engagement and collaboration core in the Frontiers Translational Science Institute. I just want to welcome everyone here today. It's exciting to have alumni back on campus, as well as joining us virtually. I think we have a mix today of not just of alumni, but also maybe some students and faculty and staff. And we've got, like I said, a couple of great panelists here today. So we'll jump into introducing them here in just a second. We're going to be recording the session, so the alumni office will have it available to send out to others in the future should people have an interest. And we'll have some time at the end for questions and some discussion. So if you come up with questions as we're going along, please feel free to raise your hand or put your hand up in your Zoom thing, or put something in the chat if you're on Zoom. For folks that are on Zoom, if you don't mind in the chat, maybe throwing your name in there and how you're connected to KU and KU Med, that'd be awesome to see that in the chat for those of the folks joining us on Zoom. But again, we'll have time at the end for questions, but if something urgent comes up, don't hesitate. We want this to kind of be informal if we can. So I'm going to start in with our panelists. We've got both Matt Kleinman and Hope Crable here, but I'll start with Hope. So Hope is the executive director of the Masonic Cancer Alliance, the outreach network of the University of Kansas Cancer Center. She also serves as the assistant director of community outreach and engagement for the University of Kansas Cancer Center. Hope helped launch and develop the PIVOT program, which is the Patient Investigator Voices Organizing Together program. That's a patient research advocacy initiative she'll talk some about today. She also supports KPEPR, the Kansas Patients and Providers Engaged in Prevention Research, primary care practice-based research network that I'm involved with, as well in the Masonic Cancer Alliance. She served as the chair of the Missouri Cancer Consortium from 2018 to 2020, co-chaired the Health Equity Work Group of the Kansas Cancer Partnership from 2019 to this year, 2022, and she currently serves on the Kansas Cancer Partnership Steering Committee. She's also serving on the National Lung Cancer Roundtable State Initiatives Work Group. She's got a ton of experience collaborating with community partners in all her years at KU Med Center. She helps those partners develop evidence-based cancer-related and public health interventions to address cancer inequities. She's got over 25 years of experience in cancer control, research, program management, and evaluation. She received her master's in social work from Washington University in St. Louis and her bachelor's of science in nursing from the University of Iowa. So Hope, I'll let you throw in more introduction and maybe briefly describe the PIVOT program, as well as describe the Masonic Cancer Alliance for us.
Thank you, Alan. And he not only is part of KPEPR, he's the medical director of KPEPR and is all things KPEPR, the Kansas Patient and Providers Engaged in Prevention Research. And so I feel fortunate I get to work with Alan and his team as they push forward cancer cancer research, other research in primary care networks, and they do it in collaboration with those local providers. So I am Hope Crable, as Alan said, and my role is really to lead the community outreach and engagement section for our University of Kansas Cancer Center, which just became a comprehensive NCI designated cancer center. So we're super excited about that. And I am even more excited that NCI about 5 years ago decided that we needed to include community outreach and engagement in all things for cancer centers. NCI designation is all about research, but that research really doesn't matter if it just sits in the lab. And if only some people have access to it. In our efforts to really try to think about how are we going to assure that everybody has access to research, we decided it really is a conversation. It's a conversation with the community, and it's not a conversation after we've created and then said, now what? It's really from the beginning. And so we have engaged patient research partners who are survivors or co-survivors or those at high risk for cancer, and asked them if they would help us talk to scientists and have a conversation about what works in science, what is important, what's the patient burden for participating in that research. We started that, I think, about 5 years ago, maybe 6 years ago. And we also decided we had to walk the walk. So we asked the patient partners to become our development team and help us create what it was going to look like, what pivot is going to look like. And we continue with the patient leader team that meets every other month and designs our program. We also have some other committees like education and membership development. And with those patient partners' efforts, we have over 130 survivors and co-survivors willing to partner on research. And we pay them for their time because we think they're bringing in an expertise that we don't have. And so I get paid when I sit in on those meetings, so they get paid as well, $25 an hour to $50 an hour. So that's part of what we do. And my worry was if we belt that, will the scientists come? Because it's one thing to get people that are really passionate about their disease to sit in a room together. So we created these rapid reactor teams where which are basically design studios. We tell the scientists if they come to us and say, I'm applying for some funding, can I have a letter of support? We're like, sure. And will you come and talk to the patients first? And we ask them we work with the researchers on their PowerPoints and make sure that they have a meaningful conversation. And then we tell them they can only present 5 slides and only for 15 minutes. And then they have 45 minutes in a facilitated conversation, and it's always facilitated, to really get the patient feedback with the goal of eventually creating long-term and meaningful relationships. And we've seen those happen. So again, super excited about that. We also have been pretty good about getting people from across the state. So we've always been hybrid. So when COVID hit, that wasn't a problem because we were already doing this with all of our meetings because we needed to be able to make sure that the science we are creating isn't something that someone just gets if they come to an academic medical center, but it impacts everybody in our state. In addition to that, that was a really nice layer for what I was already doing. So I joined the Masonic Cancer Alliance, and Gary Doolittle, who I think all the people that are in medicine know in the state of Kansas, is the medical director of the Masonic Cancer Alliance. We used to be called the Midwest Cancer Alliance, and then the Masons were generous. And so we changed our name to the Masonic Cancer Alliance. And when we first created that in 2008, that was really, we thought, oh, well, we're going to become NCI designated, we hope. And we're going to have access to more research because NCI designation is a research designation. So we're going to have more access to science. And we want to make sure that we can put some of those clinical trials at the community hospitals. And so Dr. Jensen, our cancer center director, and Gary Doolittle went across the state, and we heard, yeah, clinical trials are great, and they are, but what we really need are, and we've got a whole list of what we really need: professional education, second opinions via televideo, just knowing where our patients are at in the system if we refer them to you, sort of things. And so we started, so we created the MCA. I joined 2 years later. I shouldn't say we, they created the MCA. I got to join the team. And we extend clinical trials. We have hospitals that are members, they can open KU Cancer Center clinical trials at the local community. They're the investigators. We do all the regulatory and we do all the coaching and support of the staff. The local physicians choose what trials we open because the first 2 years, no one went on trial because we didn't ask the physicians at the local hospital what trials they wanted. Now we have a monthly meeting and they select what trials we open. But we also do cancer screening, professional education, tobacco cessation virtually, a whole bunch of other things that our hospitals keep telling us they want, and we keep shifting and changing based on what the needs are. And so my whole role is really to create this structure that allows bidirectional communication to happen, and then with a focus on health equity and making sure that everybody has access to the same level of care no matter where they're at. Is that what you wanted?
That's great. Thank you, Hope. Really great. Let's move over to Matt, and I'm going to introduce him and then let him talk for a minute, and then we'll jump into some questions after that. So Matt Kleiman's a PhD candidate and community health designer. Matt uses design to collaborate with communities and improve health outcomes in the built environment. In 2014, Matt co-founded the DOT agency at the University of Kansas, an international award-winning public interest design collaboration. Matt recently joined the public health department at the Unified Government of Wyandotte County as the program manager for the Wyandotte County Health Equity Task Force, where he uses mapping, storytelling, and community organizing to increase access to COVID-19 resources for underserved communities, and to do a lot more, I know, and I'm super happy to be working closely with Matt these days over there. He lives with his wife, Sanjita, and their 2 dogs in Kansas City, Kansas. So Matt, you want to talk a bit about some of those things?
Sure. Thanks, Alan. And nice to meet y'all. So thank you for being here today. So as Alan said, I'll keep it pretty brief. My background is architecture. I have my undergraduate, University of Kansas School of Architecture in 2009, WashU, urban design and post-professional in architecture. And along the way, I thought I was going to build stadiums because I played at KU basketball from 2004 to 2009. And so I thought sports stadiums and architecture, what could be a better fit for a sports architect in Kansas City? And I went to graduate school right after the recession and saw firsthand how neighborhoods would be torn down to build stadiums. And it planted the seed in me that what would we do if we asked the community what they wanted instead for that $250 million project that was going to tear down their neighborhood. And over time, in the work I was doing, I started picking up on they wanted safer sidewalks to get their kids to school. They wanted parks where their kids could play and be healthy. They wanted grocery stores where they could find foods. They didn't have to drive miles and miles to get to food that was more expensive and less healthy for them. And that got me thinking early on, maybe that's what I should be doing with my degree and career, is to serve communities. The problem is that the field doesn't exist. There is no job out there where you can get trained to do that work. It's ironic that we sit in this building today because I worked for the firm that built this building. And I was working on their project at 27th and Prospect when I got really dissatisfied with architecture as a whole because we serve our clients. We don't serve community. And so I started this whole process for myself as a professional career journey. I went back to KU and started teaching, and teaching turned into working with communities through groups like the KU Work Group, Applied Behavioral Health and Sciences. And Vicki Colley-Akers is now at KU Med. She was leading these initiatives. And they were doing park design where they would put in fitness trail station elements. I would say, who's your architect? And they'd say, why would we need an architect? Why would we need an architect at all? We're just going to do it. And that was our entry with Dot Agency, that there is a role for design to play in bringing up the voices of the community. Oftentimes when they want a park or a community garden or any things that improve the social determinants of health, they're often met with resistance. And so our role at Dot Agency was, how do we get to a yes? How do we use the skills of mapping and research and design? And I started doing a lot more public health research, which started me taking over to methods of community-based participatory research. I was taking courses at KU Med, looking at qualitative methods as a way to bring that back to the design process. And over the years, my sort of career shaped by public health included building a mobile grocery store that's now, it's not currently operational, but it was operational during the pandemic, handing out 120 food boxes a day for a full year. It's included things like now we're talking about affordable housing and talking about land bank and land trust and the health equity implications of having land be led by community members. We're talking about cancer and how there are members of our community who can't receive cancer care because they don't have social security numbers. And so there's so many things that health equity brings up these issues. And my experience has been trying to facilitate and organize and present tangible things. And so the Health Equity Task Force is a group of community leaders. I started a year ago as their program manager, but they started April 2020. And it's largely because of the work that Alan was doing with other community leaders, Broderick Crawford and Rachel Jefferson, and Dr. Aaron Corvo and Julianne Van Loo, our public health director, who said, look, if the health department does what it always does, it might screw this up, this response. And let's let it be community led. Let's get the resources allocated in an equitable way. And so the Health Equity Task Force, the group that I've been managing, has been working really hard over the last 2.5 years to organize and facilitate pop-up testing and events where we're not just bringing in COVID tests and vaccines now, we're also bringing in food, we're bringing in eyeglasses. So for folks that don't have vision care, they can get free eye exams and get rapid prescriptions created. There's a lot of social determinants of health that we're working on through a lot of the programs we're doing, but it's starting to evolve. And one thing I just want to point out is projects like the box in the center of the room. It's a Corsi Rosenthal box built by kids at Mission Adelante. We've built 40 of these over the summer. We're working with Wyandotte High School potentially this spring to have a health equity curriculum, because one of the things we know is that we need to have our youth engaged around issues of health equity so that there's seeds for the future of how not just learning about health equity, but learning about environmental justice, learning about how the built environment impacts their health and how they can be agents for change in their own communities. So I'm really excited to be here with y'all today. I really enjoy the work we're doing. And I appreciate Alan for inviting me, because I know Alan has been a leader in our community to kind of pull the pieces together. And I think that's what we need to do more of if we're going to actually really address health equity in Wyandotte County.
Thanks, Matt. That's so good. My first question, you kind of covered it, Matt, in terms of where your passion to jump into this, in some ways, kind of a trailblazing field for design and architecture. How about you, Hope? What sort of kickstarted your career journey, or and the passion behind kind of the things you've been doing around cancer?
When I first started nursing, I worked in a level 1 trauma center, med-surg ICU, and it was pretty fun, right? Like I could see immediately if I did something, did that person's blood pressure go up? Did it go down? Did they get the outcome that I was looking for? And as an ICU nurse, you get to literally do this chemistry experiment sometimes, right? Immediately. And I loved giving the care at the bedside. It was really important to me. But I looked around and everybody there probably could have avoided that day that put them in the ICU. And I was like, well, this is not going to quite do it for me. I need to, I want to see bigger change. It takes longer and it's harder to see sometimes. And just so over the years, I kept evolving to doing research, HIV prevention, diabetes prevention, and brought me to KU, where I realized that I wanted to be part of the solution, but I also wanted to build the healthcare providers and the community members, similar, I think, to what you're doing, really, is to create those voices, those conversations and the solutions, because I knew I didn't have the solutions. And so that's where cancer is the vehicle. Cancer, there's a lot of funding in cancer right now, right? And so it gave me the opportunity to connect healthcare providers across the state and those who are receiving the care to start determining some of the solutions and building on the science so that we can decrease all the diseases. And growing up in a rural area, it was really right for me to make part of my career as in a rural area. I was, I had a family medicine doctor at a critical access hospital that actually closed a week ago in Iowa. Was my individual healthcare experience. So it's a combination of wanting to connect, wanting to make the world healthier, but knowing that it's the people in the state that will do that.
Yeah, no, that's great. Thank you,
Yeah.
Hope.
Alan, I know you said I already answered it, but there's one thing I'll add just briefly.
Yeah.
What triggered a change for me was I was working in the northeast area of KCK, and we were doing an active living trail where we were putting signage up about reducing A1C levels. And it was designed around physical activity and reminders in different languages. And it was a really fun little project. We had like a couple $1,000s. And I was doing a park observation before and after to see if people were noticing the signage, if the surveys and all that. And I was watching on my phone as I think it was John McCain voted not to kill ACA, right? Like Obamacare was on the chopping block at the exact moment I'm sitting there and I'm thinking, I could design the best park in the world. And if everybody in Wyandotte County just lost their health insurance, like what difference does it make? And so I think for me, that's what's sort of mobilized my own development to be more specific in addressing the systemic and barriers to health, because those things are more than what we can build in a project or an initiative. Like that's policy, that is changing systems for a lot of people's lives. And so that's also a design process. And that's how my recent evolution has gotten to me to where I'm at today.
Yeah, no, that's great. So these next few questions, I'll kind of ask you both to address them, and maybe we'll have Hope go first and you go second, just like that, Matt. And you both talked about change. So the first question is, if you were going to give advice to others, maybe students or maybe people getting out there in health related fields, and they wanted to see change, they wanted to see communities or populations of individuals have improved outcomes, what sort of advice would you throw out to those people as they're doing that work?
Well, I think we have a friend in common, Broderick Crawford, and he is this amazing gentleman who has pushed us at looking at how we do business and push us in how we address equity. And he's not available to tell us all those things right now, but some of the things he would say to us is, nothing is for us if we're not included, nothing about us without us, right? And so I think the first barrier is we don't bring the community or whoever's impacted to the table, whether it's a healthcare system, it might be the administrators making the decisions and not always bringing in those who are at the bedside, whether it's research, we're not bringing in the patients to hear what the burden is or what the challenges are. So I think one of the barriers is really making those connections and allowing for that bi-directional communication, but also then really hearing it and help and allowing that to guide us, which can be a real challenge. So I think it's the communication and listening is the barrier.
I would second everything you just said. But I would also add, so my first sort of entry into this work, I didn't want to assume that I knew what community engagement was, because architects do a lot of community engagement and it's usually terrible. There's a whole history of it in urban planning that what we often call community engagement is just informing the community about what's happening to them and not actually inviting them to be co-participants in the process to build power with them, so that long after your project is gone, they're still the leaders in their own community. And so I was aware of that, and I found in the Clinical Translational Sciences Consortium the 200-page report on the 9 principles of community engagement, like my Bible of what community engagement ought to be. And they define it very clearly. And so part of what I did is I adapted that, and I got to write about that because I had to think about how that affects my process. And the first step is you got to be present. Like, you have to be in these communities. And oftentimes it's a barrier for the health field, because we are quite literally in an ivory tower. It's a barrier for the health department. Like, if you've seen the health department, it's a white building that you got to validate your parking. You got to get through locked security doors before you can even talk to a person. And so oftentimes, my experience is I see people with really good intentions who have either grant funding, or they have the energy of students, or they have a heart for the community and they want to do something, and they show up and they say, here's what we're going to do. Do you want to help us? And I often tell them that's the wrong response, because I had to learn that the hard way. I got called out so many times when I started doing work with that agency. And what worked for me, I think works for others. And it's what the CTSA says you should do, which is you show up to other people's stuff and you bring them the resources you have. What do you care about as a community? What do you work on? Okay, can I help get you that connection? Can I bring that grant funding to you? I don't need to be the agency that receives it and subgrants it to you. You own the work. And what happens is as you lift up your community partners, they build trust with you. And then 2 or 3 projects down the road, they trust you enough that when you say, hey, do you want to help us on this thing? That relationship exists. And oftentimes that's the biggest barrier because we're so constrained by these arbitrary grant deadlines and rules and procedures, and this academia can be a barrier, politics can be a barrier. But what I've learned is I've been doing this work in Wyandotte County for 8 years, and the same community partners I've had in year 1 are still with the work I'm doing now for the most part. I've gone through like 6 different jobs in the same time. So building relationships for the long haul and letting communities own the outcomes is something that is the hardest thing, I think, for a lot of folks that do community engagement. But that's what we're told we should be doing from the highest level at the CDC and NIH. It's just, it's hard to do because we're not trained to do that. Architects aren't trained to do that. Public health's not really trained to do that. CBPR is getting us there closer, but it takes being in the field and being in the community over a long period of time to build those types of relationships that makes that possible.
But Matt, I would argue that it's going to take a paradigm switch too, right? Like you were willing to give your time and your treasures. And I think that's really fantastic. And it does mean weekends and evenings and a lot of time. And if you're a young faculty member here, you're not getting extra points for community engagement. And you are going to get your professorship if you get funding and if you publish. But really that whole piece of community engagement, even just participating in research and putting patients on trial, the researchers do not get protected time. And so it's going to take a paradigm switch. It's going to take funding. We with Cancer Center, we've started like, okay, what programs are happening in the community? We have to sponsor that. Well, what's the outcome of that program? Well, we have to sponsor it because we have to be in the community. And that's one of the ways that you're in the community, right? But it's taken that paradigm switch. I think we're trying here at KU. We're beginning to have those conversations, and it's hard but it is hard. Even at the health department, you have outcomes you have to count, right? And so really figuring out how to give that space and how to articulate the value is an ongoing project. And it's a barrier for everyone deciding to go out in the community.
Yeah, it's definitely super time consuming. And, but you guys are great at, at establishing the value and describing that value. Which is helpful. I mean, I think we do have some real national leaders like you guys in this right here in our region. Let's skip over to another topic and talk about equity a little bit. There's lots of talk about health equity these days. I'm at a health equity conference right now. What does that look like to each of you in the arenas within your operating? What's it look like, and what are some other things that you think can help us get there?
I always go first.
So there's the definition that the CDC uses that, health equity is the ability for everybody to attain quality health, no matter their race, ethnicity, religion, socioeconomic status. And I think all that is true. This comes up in architecture world because there's a movement towards what's called design justice. And the argument that they're making is if you aim for justice, equity, diversity, and inclusion will follow. And I think sometimes we fall short of that, where we aim for diversity in healthcare or diversity in public health or inclusion in public health. And equity is kind of the next buzzword that everyone's starting to use, and it's starting to lose its value. But justice is something that I think we're still sort of on the forefront of. And what health justice might look like is addressing for systemic injustices in our built environment. And I bring the built environment back into it because there's a lot of MCOs and organizations across the country that are starting to identify the impacts of racism as a spatial thing, right? Redlining didn't happen to everybody equally. It happened to specific neighborhoods on specific factors. And we look at environmental justice right now, where air quality and water quality are polluting the community members at a disproportionate rate, especially in those Black and brown communities where factories have been allowed to be located next to them because nobody was looking out for their interests when the factory said, hey, we're going to zone this area industrial and you're going to be right next to a neighborhood where kids are going to play in the shadow of a coal factory, right? So like health justice is working with those communities to identify, okay, what's the remedy that you want to see? And I don't know if we're there yet as a society. I think the paradigm shifts is absolutely true. But I think that's where this conversation's going, because I do think, I know the health department just kind of let the cat out of the bag that we're working on declaring racism as a public health crisis, hence why I'm wearing the shirt. Because that means now we need to have cover to go out and implement programs and policies that actually stand to change the systems that are impacting health. What that might look like for Wyandotte County, I'll just give you one snippet of a project. Justice 40, there's that word again, justice, is the federal government's response to climate change. And they've identified the 90th percentile vulnerable census tracts. Surprise, Wyandotte County has 20% of them in all of Kansas. It's basically half of Wyandotte County, the eastern half. Those are the areas that ought to receive the majority of the federal funds available for reducing the impacts of climate change. So when we see heat island effects, when we see stormwater overflows, we saw what Jackson, Mississippi just went through, where their water was so contaminated, people are getting sick from it. We have decades of redlining, which led to a lack of home loan renovations, which led to lead paint and lead in the water systems. Like there is an issue of justice, and how do we address that? And so I think part of what the Health Equity Task Force is doing is starting to pick up on how do we look at those health disparities? And this is what COVID is teaching us. And identify, not at a zip code, not at a county, not at a census tract, really neighborhood by neighborhood. Where do we see health disparities and how do we address them? How do we bring resources to change, to help people in the moment and also change the systems so that that doesn't happen again? So we're looking at the Justice 40 initiative saying, can we do green lighting, where we have an environmental designation that anytime anybody wants to build something that's going to negatively impact the environmental health, there's now a public health department review to say, is this actually going to impact people's health negatively? So we have systemic policies that protect the most vulnerable residents of our community. So that's kind of where I think it's going. I think health equity can kind of get lost in the terminology, but I think a focus on health justice might be where we go next.
I love that. I had a panel earlier today with the researchers and pharmaceutical sponsors of research, and we had someone from the Kickapoo Nation on the panel I was on, and she was talking about the environmental issues and how the solutions are in her community. And her mother even started writing grants back in the day and brought the 638, which is a tribal run community health center, to their area. And she used the word, and I agree with the word justice as well. I think when we are working on it for clinical trials, and we've really started thinking about what are we doing to assure that everyone that has cancer in Kansas has equal access to clinical trials. And the question might even be, and I will remember Broderick asking me this question, but if African-American women are more likely to die of breast cancer, more likely to have breast cancer, is just having an equal participation, is that enough? Or should they have greater access to clinical trials if they want it? Should we be creating clinical trials in a way that really addresses those particular needs? And so we're looking at both. We have a clinical trials awareness campaign that was informed and developed by TICO, which is a minority-owned cancer survivor organization, media productions company. But awareness isn't enough, because if you come in to get care and your provider doesn't ask if you're interested in participating in a clinical trial, you can be aware as you want, right? And maybe they didn't ask because our eligibility criteria for clinical trials are so narrow because they're based on healthy white women for eligibility criteria. So is that just a cut and paste where we've not really looked at the science and decided we needed to expand the eligibility? Maybe it wouldn't impact it. Maybe the burden is too much, or maybe we haven't addressed the social determinants of health for that individual. But they might be very willing to participate, but Can they come from a rural community and stay overnight on a trial? Can they get here from the neighborhood? Is the bus line 2 hours? What are the barriers that are keeping those individuals? And can we reimburse them for their time? It's not enticement when you're reimbursing someone for their parking, their transportation, and their missed work. That's just reimbursement for their time, right? And so we're really trying to look across all areas and are we really asking every single patient that walks in? Or are we making judgments about their capacity to come back for that next appointment without exploring with them if that is an issue and how can we help you with that if it is? And so we are meeting about every 3 weeks right now at the Cancer Center, really trying to explore from awareness through dissemination of results and all the things that impact someone's ability to participate in a trial and a provider's willingness and ability to offer it to the person, which might be, I think it might take too much time because they speak another language. So I'm not offering it to them because I'm not going to take that extra time. So how do we protect that provider time? And so equity, just in one window, that's one of the ways that I look at it and think that anybody, whether they live in Goodland, Kansas, a frontier county, should have access to a clinical trial, or Wyandotte County in a neighborhood where transportation may not be as good, right? Like everyone deserves it, and all the providers need the space to be able to be confident and share and provide that resource to their patients. Because I think it's equity for the providers and justice for the providers too. It's kind of that moral dilemma you have at the end of the day when you feel like you couldn't do everything you wanted to do because you just don't have the time.
Yeah, no, those are great thoughts. I'm going to go on to another kind of sort of hot topic that lots of people are talking about these days, and that's social determinants of health. And I know that that's really central to a lot of the things Matt's been doing. But I wonder, what are your thoughts about how that's kind of gotten into the healthcare and the public health lexicon, and how what sorts of things need to happen to really make impact in those arenas so that we can get some of those equitable outcomes we want to see.
So I can't take credit for my awareness on this, but Community Health Council Wyandotte County is sort of where I came up doing this work. They're a sort of, I'd say they're kind of like a mini health department, but they do a lot of community health workers in a lot of different languages. And that's kind of how I got my start in Wyandotte County. So a lot of credit goes to them, but they made the point that social determinants of health implies that your health is determined by your social environment. And it's actually more that it's a factor, but it's not the only factor, because all of our social environments exist under a political landscape. So I mentioned ACA earlier, right? So there's more and more evidence that it's the social and political factors of health. And so we're talking about policies, we're talking about laws, we're talking about ordinances. And I think that's something that it's interesting, because the systemic barriers that our community experiences sometimes are the result of policies that have either been poorly written, or they've been overlooked, or there hasn't been a policy to address the health disparity that we now see. And I'd be remiss if I was talking about this and I didn't mention how we're doing that in Wyandotte County. So when the pandemic hit, Broderick, Allen, a lot of other community leaders said, hey, we need to have a boots on the ground approach to address COVID as the health disparity it is. And so the disproportionate rates of who was impacted by COVID led to a lot of pop-up testing, and then eventually vaccine events. And we learned along the way, in sort of an adaptive, iterative approach, what worked and what didn't work. So when the health department's open from 9 to 5, Monday through Friday at one central location, you got to be in neighborhoods to discover that Juntos, out of the KU health system, was having churches where immigrants and refugees were coming in, and they were lined up around the block from till like 6 to 9 p.m. on a Friday night. And that worked. So how do we do more of that? And so the Health Equity Task Force has learned from our partners outside of the typical systems to reach those communities that typically don't get reached. And I think that that's the kind of work that we're now realizing, okay, so we can map out neighborhood by neighborhood, not census tract, but neighborhood by neighborhood where there's a high density of unvaccinated individuals, bring testing and vaccine sites to trusted community locations near them, canvas 100 households per event, doing that in 4 different languages. Right now we have English, Spanish, Swahili, and Burmese. And then it's got a calendar inside that shows where all the events are. We have 40 in October. And we're starting to realize that, COVID money won't last forever. So what we're trying to do is layer in these social and political factors of health. So can we start doing voter registration? Can we start doing food drives? The Health Equity Task Force right now is working with me to help develop a culturally appropriate food box. Because when Harvesters, our local food supplier, would bring food, it's not necessarily addressing the food needs of the communities that are receiving them. And so those other factors can start to play a bigger role, but we need to not only know about them, we need to know how we're going to organize as a community to actually respond to them. And that's where the rubber meets the road, and that's where it's a real challenge. But I think we're building that infrastructure that we wish we would have had at the beginning of the COVID pandemic now to address these other factors.
Oh, that's great. Hope?
Yeah, and I would just say that we are seeing this to be a question that healthcare providers now have to ask, right? And all of a sudden you're looking outside the walls instead of inside the walls. And it's really hard because now we're measuring it, we're asking questions related to it. And if you ask an individual a question, especially if you're the healthcare provider, they're assuming you're going to come up with a solution. Like you're not just gathering that information, right? But we're not, there's very few social workers embedded in programs that can help connect it. And there's very few, we ask about financial toxicity, we ask about food, we ask, but do we have a solution for those individuals? And so part of our job is try to connect the people that are concerned, that have access and are doing the food drives, to the people that are asking the questions, what are your needs? So that if we can kind of create a matrix, but I still worry, and I don't think we have a solution. I'm working on the Breast Cancer Health Equity Task Force, and we need to do system level approaches. And I don't think we've really come up with the solution yet, right? Like it's going to be something that we're going to be working on for a while. We are working now at a thing called financial navigation. Have you all heard that term financial navigation? And it's cancer centers. It's a new buzz thing because, it's cost $250,000 to get a round of treatment for some cancer care, right? Really expensive. Like how does anybody pay for that, much less someone that is, on day 28 of the month already holding their breath, or day 15 or whatever it is where they begin holding their breath. And so we are looking at, there's something called insurance optimization that financial navigators do. Like you can switch people's insurance. They can all of a sudden be qualified for the ACA. Their Medicare may be better if they switch, once they have a qualifying event, which is a cancer diagnosis. And there's all sorts of resources too. But it doesn't fix what it does. It's not a system level approach in the end. Like, it doesn't address that we don't have, everyone doesn't have insurance for healthcare in the end.
And we experience that same issue. It's like, what can you do in a year that took decades for us to get to this point? I think that's why we've gravitated towards things like the Corsi Rosenthal box, because at least there's something that's tangible that raises awareness around an issue, that you can bring youth or people that are most impacted on the front line to be a part of the conversation. And that there's something that you can say, hey, we're building momentum around, even if it's a small piece. It's really hard to do this work if there's not something you can say, hey, we made a difference, even at a small scale. And that's the real hard part, is how do you do this work, identifying things that can build, the terminology is the things that make the things that make the things. And so how do you address a system at a way that's tangible and real? And so a lot of groups I've seen, it's reports, or it's storytelling, or it's art and community building, because it's really hard to address systemic level change.
Yeah, and that's why with the Breast Cancer Health Equity Task Force, we also have what we call friend-to-friend events, which was a approach where you engage breast cancer survivors from the community to talk to individuals who are considering getting mammograms and have parties, celebrations, and conversations. And we bring in a mobile mammography vehicle. And we've been doing that at churches, but we're like, well, maybe we need to be doing that at somewhere else. Like maybe a church is one location, but maybe we need to do it where food's being distributed. Maybe we need to do it not on a Saturday morning, but a Friday evening. And we're having all those conversations about what are the things we need to do to reach the women who are impacted by a high risk of cancer. We are partnering with Andy Godwin has provided funds for us to provide free genetic testing and counseling, because maybe bringing a woman in to get screened for their mammogram the first time at 45 isn't such a great idea if their mom died at 35. And we need to really make sure that we're even identifying individuals that are at higher risk for cancer so that they can have access to those services. So we're trying a variety of things. We do that one project with Casey Cares. And so we have several projects like that out there. And I think it does it. What keeps you going as you try to make those changes that can be sustained.
Yeah, it's definitely hard work, but I think both of you are hitting on an approach. I have this old talk that I used to say, just do stuff. It's to do because it's really hard. It's these things, they're so structural and complex, but we have to keep battling them. And maybe it is just doing stuff. And the boxes I think are a great example of that, Matt. So really good. Well, I think we got to sort of wrap up. I think, in fact, we're over time a little bit, but maybe we take at least a couple minutes to see if folks either online or they're in the room have any questions.
There is a question in the room.
Great.
Yeah, sorry, I glossed over it. It's called a Corsi Rosenthal box, CORSI. Corsi is a professor at UC Davis, California. Rosenthal's an engineer out of Texas. And they figured out, I think this was initially for wildfires, but they figured out that when you put 4 MERV 13 air filters together, and you tape a box fan on top, it is creating sort of a vacuum inside the box. And so the fan is sucking air from this room in through the filter, and the filter catches the particles that carry COVID-19 and it blows the air back out. And so it's effectively cleaning the air. It turns the air over about 6 times per hour, which is what the original recommendations from the CDC were. I know Alan uses a Swiss cheese diagram of all the things we could do. So wearing a COVID, wearing a 95 mask, there's more advanced versions that do this kind of stuff with UV light, but this is about $100 and it competes pretty high efficiency on a dollar per cost basis. It has the added benefit that we can build this with 5th graders. And so it's a STEM education project. And so that's what we've been doing and trying to figure out how we can work with the schools to do it. I don't think these are like a foolproof solution. They'll probably last for a year before the filters are start to get dirty and you might want to replace them. But in the immediate term, it's better than nothing, and it can help prevent COVID. So that's what we're trying to do and trying to get these into areas. We have them right now at churches and at local neighborhood community spaces around Wyandotte County. Because from a health equity perspective, the cost to do that, and KU Med might have a few of them around here, but not everybody has KU Med's budget. So that's where we're trying to address it. Yeah, the HEPA filters, like the high-end ones, can get up to 1,000. And so there's a lot of research being done around the country on these, and they outperform a lot of the more expensive models. Yeah, if you scan the QR code on top of the box too, it takes you to the webpage on how to learn how to build more. So we're trying to spread the word.
Time for one more.
I just have a comment. I'm a Wyandotte County resident, and it's always bothered me that there's no indoor swimming pool or outdoor swimming pool in Northeast Kansas area. Like no place to work out. There's gyms, but
Yeah.
I mean, they're all over Johnson County. That's where I go swimming.
Right.
You know,
I know Parkwood Pool is the only public pool in Wyandotte County.
Right,
It's in the
it's so
northeast area.
little.
Yeah, I mean, this is, I mean, what we're dealing with is the consequences of white flight, right? When Johnson County was born, it was because white people fled the desegregated schools of Wyandotte County. Like, and with them goes the property taxes, and there goes your pool development. Like, that's a lot of the health resources. So we're still experiencing, and to get back to that requires a major investment. And I don't think there's a silver bullet out there. I think there's a lot of competing interests, but I appreciate that because I live in the Northeast area myself, and I would love to have a pool that we could go to.
and I also have a comment. There's a nuclear bomb parts plant in Kansas City, which people that live in Kansas work in. And it's 14 Superfund sites located there. It was Bannister Federal Complex. And many people are still suffering health effects and dying from cancers that work there. And also there's Richards Gebaur Air Force Base that is highly contaminated with PFAS. And a couple of my friends have died from cancer or had lupus that live in Belton.
And the Harcrow Chemicals plant is also another one where the rates of cancer are like 9 times higher than they should be anywhere. And it's the fumes from that area. ProPublica did a report in Wyandotte County. And you think about, we have the second largest rail line in the United States in Wyandotte County, but you go down to Argentine, there's homes right across the street from the train tracks. And so there are so many environmental hazards, and a lot of research has been done about how, well, how do we get this far? Well, it's because nobody stopped it. Nobody thought, let's prevent that. And so now we got to figure out how do we address that? And then like how, you know, some of that's regulations to prevent the next one, but there also has to be organizing and advocacy to make a change to the ones that are there now.
Yep, lots to do. Well, we probably better get it wrapped up here. Maybe you guys can have some more informal discussions if you have time back there in KC. But thanks so much for everyone for coming, and thanks so much, Hope and Matt. The things you're doing are phenomenal and really inspirational. And please keep doing them and keep trying different things, keep testing things because it is going to make a difference and it is going to make headway over time. So thank you. Let's give them a round of applause. Yay. Everybody have a great weekend.